shallow AC and small pupil. So Dr. Sourabh is here to speak first, and then he's got to rush for a judging session. So if there are any questions, we'll take them at the end of his talk. Thank you, Sourabh.
Thank you, Dr. Swain sir, for inviting me for this very, very useful instruction course on small pupil. I think you are playing from there. I think one of the things which I always hear from my trainees and fellows about whenever any complication occurs, their statement starts with, then the pupil became small, and then this and this and this happened. So I always tell them that small pupil should not be an excuse for making a complication. So I will be talking about a deadly combination which is shallow AC along with small pupil. So when we have shallow anterior chamber, that means there might be associated zonular weakness. There is always inadequate visualization because of small pupil. There is higher risk of iris prolapse with shallow AC, probability of aqueous misdirection on table, inadequate staining of the capsule, and there is always, because you have very small working space there, risk of endothelial damage there. Now I want to show you some tricks, to determine how the surgery you are planning. So how do you determine whether there is significant phacodonosis or not before you plan which type of pupil expansion device you are using? So I just take a simple Sinski, make the entry, and after that, just after putting the staining and OVD, I just touch the anterior capsule and try to move that lens around. So if there is significant amount of movement of the lens noted, then I generally go with the iris hooks because I want to assess the zonular damage all throughout the procedure. But if it is not significant movement, then I can go with B-hex, which is my pupil expander of choice. Another thing to show here, how to stain the anterior capsule under the iris, because many times there is small pupil to begin with. So if you just stain in that area, the periphery remains unstained and you may have trouble while doing rhexis later on. So stain under the capsule and then use heavy dispersive. My choice is Hylucoat. And whenever you have these rigid pupil, before using B-hex, it is better to do little bit of stretch pupilloplasty and then put the B-hex ring inside. Of course, more about the B-hex ring, I think the inventor himself will later deal with. Some of my choices with B-hex is, one good thing is very, very thin profile. So even if there is shallow anterior chamber, it doesn't have any issue. I generally try to put the subincisional flange under the iris so that that avoids the problem of IOL haptic getting entangled with the B-hex. Now, whenever you have small pupil shallow AC, always the good size of CCC is must. This is another problem with many surgeons do, is that they make smaller rhexis, even smaller than the pupil size, and then you'll end up with more trouble. In generally with shallow AC and pupil expansion device, I remove the B-hex device under visco only, because if you try to do hydro explantation, there is a higher risk of iris prolapse. Now I want to show a case of nanophthalmos where there is extremely shallow AC, hardly 1.2 millimeter anterior chamber there, with intumescent cataract, one-eyed patient with iris is almost completely plastered to the anterior lens surface. So again, I tried staining the capsule under the iris, but it was not possible because of Synechiae. So now I am going to put Hylucoat and release the Synechiae first. Sometimes you may find a pupillary membrane which you can remove, but sometimes pupillary membrane is not there. So you just have to separate the Synechiae using any blunt instrument like iris repositories, or you can use a blunt Sinski hook as well. And then little bit of stretch pupilloplasty before we put the B-hex. Frankly, this B-hex has worked for me in all these cases, particularly shallow AC, because it has such a thin profile that anterior chamber is not lost. Now, once B-hex is inside, we have pupil of adequate size. So that particular problem of in the case is now solved. Now, once we have that in space, now you can see the anterior capsule is not well stained because of the thing that I could not stain it under the iris. So what you can do, you can just paint the anterior capsule under the viscoelastic which you have used. Of course, it is always better to have a cohesive OVD under which you can stain it much better way, but it's possible to do under dispersive also. After that, I have removed the OVD and again checked the staining is adequate, then I have again replaced the OVD, otherwise I can remove and restain. So always make sure the anterior capsule is well stained before you start. Again, after making the first nick, because this is an intumescent cataract, I just aspirated little amount of cortical matter there, so that there is no problem with the intumescence later. And again, with this very, very small eye with intumescent cataract, I have to make sure that still I get adequate size of the capsulorhexis so that I don't do further zonular damage while I am removing the cataract. So all throughout, always remember, whenever there is any doubt, always use pupil expansion devices or iris retractor, because small pupil should not be an excuse for any complication. So in this case, it was a very large customized IOL. It has a lenticular design, so usually overall thickness is not that high. The thing about, as I told, that trailing haptic, you have to be little bit careful while using pupil expansion devices, that it should not drag that device into the bag along with it. So you have to be little careful while doing that. Make sure you do it carefully, and then you remove the pupil expansion device. The next case I am going to show, that is the common problem of iris prolapse which happens. Here, nasal side, this is again one-eyed lady with adherent glaucoma. On nasal side, the iris is almost plastered to the antechamber. You can see after putting the air also it's plastered. And only in the temporal side there is some amount of anterior chamber. So I want to make incision in the temporal axis. And now watch, I had stained under the iris, I had put trypan glue, and this happens. The iris starts prolapsing. So now let's think, whenever there is an iris prolapse, we have to find out what are the possible causes in that particular case. Like it can be OVD overfill, it can be a short incision or very large incision, posterior entry, raised IOP, raised intraorbital pressure, floppy atonic iris, small pupil, shallow AC. You first find out what was the cause in that case and then move forward so that you treat the cause. So find and treat the cause. So what was the cause in this particular case? Was the trypan glue which I had injected got trapped under the iris, and when I injected the OVD, I did not make the movements from periphery to center. In fact, I just injected from one end to another. On the other side, the iris was plastered, so trypan glue got trapped in the subincisional iris, and it caused the iris prolapse. Now just see, as I release the viscoelastic, the trypan glue is trying to come out, but because I have used heavy dispersive OVD, the OVD is not coming out easily. So now my plan is to have 2 incisions for bimanual, then another 2 incisions, little posterior scleral for making, putting the iris hooks, because I want to drag this iris back a bit so that I can do the rest of the manuals. So now I am going to release the OVD from the anterior chamber, and watch, that was the cause, the trypan glue trapped behind the iris, and once I release that, I could easily put back the iris. If I would have tried 100 times to put that iris back, I would have just damaged the iris and nothing else. Now I use iris retractors to pull the iris back. Maybe I could have used one more under the incision so that even that iris is protected. You can see on the nasal side, when I tried to put the iris hook, in fact, because of the adherent glaucoma, it went behind the iris. So this was a reverse iris hook which was used. The capsulorhexis was done in the usual way. Again, even if there is a small CC, you should avoid very, very tiny capsulorhexis in these cases. Always detrimental for your surgery. Zonules get damaged if you have very small rhexis. Now, one thing is that always put the phacoprobe inside the AC without irrigation on. So if you keep the irrigation on and enter the AC where there is already iris prolapsing, the irrigation enters the AC first and then it causes more iris prolapse. So follow this ritual, put the irrigation off, go in, while before taking out, make sure you stop the irrigation, let there be little bit of hypotonia and then come out. Always in these cases avoid temptation to keep on pushing the iris back inside. Rather complete your procedures, avoiding further damage to the iris while using the putting the IL also. You can put little bit of heavy OVD over the iris to keep it back, and then you can put the IL so you avoid further damage. Once everything is done, your AC is hypotonous, then you can safely pull back this iris. Now I will suture the incision before I remove remaining amount of OVD so that I don't have now any iris prolapse further, and that way you can manage a case where there is already a iris prolapse. Thank you so much, Dr. Suven.
Thank you, sir.